Sure. A very good evening to everybody. I am Dr. Sowmya, a senior consultant in DNB faculty at Shankar Eye Hospital, Bangalore. We are here with Titan to create an awareness about refractive errors in children. So we start off with the discussion on refractive errors in children. So the overview of the presentation would be, we will be looking at what are various types of refractive errors. How do we know that my child has a problem? What do we do, or when do we take the children for consult? Why does this happen? Why does a refractive error happen? A little about myopia or short-sightedness in detail, and what can we do if it increases over a period of time? Do we have measures to control this? And a quick summary and things to remember. So first, let's look at what are refractive errors. The eye, as we all know, is akin to a camera. So basically, when we look at camera, there are a set of lenses which help the object to be focused onto our image. If you look at the camera per se and an eye, you can compare this to that basically that if you had an older camera where the image would be filmed on a reel and that would be an inverse image, a similar thing happens in the eye as well. So it's basically that there are two important refractive elements or two important lenses in our eye which help the object to be focused onto the retina. The first one being the cornea, that is the black portion of the eye or the center of the eye which you normally see. The second one is the lens which helps focus the object onto the retina. Previous slide. So if we actually look at this, the objects or the light has to be focused exactly on the retina. When I say the retina, that is the back portion of the eye on which the image is formed. And this image would be processed, or the information from both the eyes is sent to the brain, and that is where the image is reinverted and we tend to perceive the image. So that's how an object is seen by our eye. That is essentially means that the eye is like a series of lenses which help us see the object in clarity from the eye. So when we look at what happens if these lenses are not working exactly, that means if the focus is a little more or little less, imagine yourself looking at the camera or taking a picture, having an DSLR camera. When you use extra lenses to focus at a distance and you remove the lenses or use zoom lenses to focus at near, that means the eye essentially is able to provide the entire range. If the object is not seen clearly, the rays of light, what happens, they can, instead of focusing on the retina, they can be focused in front of the retina or behind the retina. So if they are focused in front of the retina, what happens is essentially what we call as a myopia or short-sightedness. When I say short-sightedness, what I essentially mean is the near things are very clear to us and the distant things are not very clear to us. In layman terms, we would say it as a use of minus lenses. So when we look at the rays of light being focused behind the retina, so what happens is neither the distance nor the near is clear to us, and that is what we call as a hyperopia or long-sightedness. Lastly, what could also happen is if you're looking at it in 3 dimension, the rays of light in the horizontal plane can be focused and the vertical cannot be focused, or vice versa. So what happens is that the rays of light are not focused on the retina clearly. So that essentially leads on to astigmatism. So if you look at this image where there's a waterfall and there is a stone as well in front of it, so what essentially happens is, for a person who is now having normal vision, both the waterfall and the stone is seen very clearly. Unlike in a short-sighted person, the distant waterfall is blurry and the near stone is kind of clear. That is what we call as a myopia or short-sightedness. And in a hyperopic error or a plus powers, both the waterfall and the stone may not be in clear focus. That is what we essentially mean by hyperopia. Now, when we have understood that the refractive errors are basically because of optical elements not in place or the change in the length of the eye or the change in the curvature, what should we know further is how do we know the child has a problem is essentially by looking at a few things. The child will not come and tell you that I cannot see properly at distance or I cannot see properly at near. Essentially because the child does not have a previous comparison to say, okay, I was seeing like this, now I don't see it like this, and that's why my vision is lesser, unlike in an adult where you have a comparison to do. So you could see the child squeezing the eye, making the eye smaller, and then looking at a distant thing or near thing. That's a clue towards the refractive error. Second, it could be because of the child can be having a turning of the face. Whenever the child is looking at a distance, the child turns the face to the left or right, up or down, and then sees it. That again can be a sign of refractive error. Or the child is taking all the things closer to see it, again means the child has a refractive error. Or the child can have a squinting of the eye. When I say squinting, what I mean is you look at the child and one of the eyes looking at you, the other eye is going inwards, outwards, any direction. That could mean that the child has a power in the eye. Or the child has disinterest in the classroom or reading. That means the child was doing scholastically very well and suddenly the grade starts dropping. The child starts losing interest in studies. That again can be because of glasses. Again, recurrent headaches. Lastly, the child can actually say that when I sit in the last bench in the room, I cannot see properly. So that again can be a sign of refractive error or the child has a problem. Now, when do we take the child for a consult? That means, do we wait for all these problems to crop and only then take it for a consult, or do we go a little earlier and get a consult done? We should always get every child have an eye check before the age of 5. So 5 is usually the age where the child enrolls into school. So before you enroll the child into school, into a proper curriculum, you should get an eye consult done. The two reasons why we should get a child check before 5 years. One, we know exactly that the child is seeing very clearly when the child is starting school. Two, when we pick up problems if the child has before the age of 5, we have ample time to treat the child before the child develops a irreversible problem. That is for a normal child. If the child has a developmental delay, it's a preterm child, the child is having other issues, then probably you should get a child check done at the earliest. If the child has other symptoms, like you see all the symptoms even in a neonate, the child, or in a 6-month-old baby, 8-month-old baby, not looking at the mother at all. The child is just gazing everywhere. The child is having a moving of the eyes, the shaking of the eyes, the wobbly eyes. All those things require an eye checkup at the earliest. That means you don't wait for the problem. If you see a problem, just get an eye check done. If the problems are not noticed, the child is seeming all okay to you, then get a check done before the age of 5. So how do we check a child before the age of 5? So that is again a question most commonly asked by the parents. My child is still not speaking. Should I get an eye check done? How will you check the vision in the child? The child's eye or the vision can be checked at any age. We have age appropriate charts. We will have bar charts or a Lee paddles to check the vision. You will have picture charts to check the vision. You will have picture charts which can be used at 1 meter, at 3 meters, 6 meters to check the vision. Apart from that, we have an objective measurement in terms of getting a retinoscopy done, which gives you an exact measurement of the length of the eye or the power of the eye. That again is important for us to note what is the exact power in the child's eye. What happens? Okay, my child is, I have not got an eye check done, or I have got an eye check done. The child was prescribed glasses, but the child is not wearing glasses. Is that okay that the child does not wear glasses, or does it lead on to further problems? Yes, it does lead on to further problems. If a child needs glasses and not given glasses, what can happen is there's a blurred image which is constantly being transmitted across to the brain. What essentially happens is it leads on to a condition called as a lazy eye or amblyopia. That means the vision would start dropping day by day as and then the child grows. This could happen in one eye, this could happen in both the eyes. So a problem which was just a refractive error or the need for glasses has turned into a second problem which is called the lazy eye. Further, what can also happen is the refractive errors itself can lead on to a squint in the eye or a strabismus in the eye. That means the child is, say, the child is having a very little power in the right eye and very high power in the left eye. So what essentially happens is the eye which is having a poor vision or blurry vision tends to drift over a period of time and develop a squint over a period of time. So further, what also can happen is this blurring vision or this blurry image can itself stimulate the eye growth and cause the powers to increase more and more. So that is why it's important, if the child needs glasses, that has to be detected at the earliest one, that is before the age of 5. 2, if it is noted to have a problem, it's very, very important to give glasses and be sure that the child is wearing glasses, not to lead on to lazy eye or further problems. Now, what is also important is why does this power change, or why does this essentially happen? Why does this happen is essentially because of the length of the eye. As we looked at, it's like a camera. So it largely depends on if the lenses which are working appropriately and are appropriately distantly placed. So the length of the eye and the curvature of the cornea are the two important determinants for the powers in the eye. So how is the length of the eye and the curvature of the cornea essentially determined? That could be determined by our genes and also by the environmental influences. That essentially goes on to say it is multifactorial in causation. So it essentially goes on to say that it is not just about what you eat or what you see which determines our power. There has to be a genetic predisposition and there has to be an environmental influence which causes the power to develop. So a little about short-sightedness in detail. Why are we so worried about the powers going higher and higher? Because higher minus powers can lead on to permanent vision loss problems, because it leads on to retinal issues in terms of retinal detachments or holes. And that is why it is important for us to understand this in detail. Also, the recent data shows that the powers in children are on a rising trend. That is, it is expected that by the year 2020, that is now in around this time, 1/3 of the population is supposed to have short sightedness, and the same would increase up to 50% by 2050. That means half of us would be wearing glasses by the year of the children would be wearing glasses by the year 2020, 2050. And that's very alarming. And that is more so in the urban population compared to the rural population. Coming to the risk factors for the development of myopia per se. So the risk factors can be multifactorial. Again, it could depend on the genetics and parental myopia. It could depend on the ethnicity. It could depend on the outdoor exposure, sunlight exposure. It could depend on the physical activity the child does and the near activity. Let's look at each of them in detail. What happens in a parental myopia? So if the child is born to a parents who are having a minus power in both of them, if the risk of developing myopia in a child where only one of the parent is myopic is close to 2 to 3 times higher compared to a child who does not have parents who are myopic. Similarly, if both the parents are myopic, there is a risk nearly 8 to 9% that the child will develop myopic. So that essentially goes on to say the risk is 2 to 8% higher if you are myopic, that your children will become myopic. So especially if as parents you're wearing glasses from a very early childhood, that means this risk of developing myopia is going to be higher in a child. So that is why it is important to know the genetic history or the family history of myopia. Further, myopia is a little more common in in the Eastern Asian population, that is in Singapore, Hong Kong, etc., compared to that in South India, compared to that in African population. So the time trends essentially show that there is an increasing trend for myopia in South Asians, that is especially in India. So does this myopia stay like that? If the child develops glasses, is it going to remain like this, or is it going to worsen out with time? What does it happen? Yes, based minus powers usually increase with time. That is, the myopic number keeps on increasing. The minus powers keeps on increasing as and when the child gets older, usually till the age of 16 to 18 when the numbers usually stabilize. Unlike in a plus number, which increases closely to around 8 to 9 years of age and then plateaus down, followed by a regression, slight coming down of powers beyond the age of 9. Unlike in astigmatism, which could kind of increase till the age of 7 and 8, after that should remain stable over a period of time. Essentially, most of the children have a minus power that goes on to say that these powers are going to increase with time. So what can we do if it does increase with time? Earlier we thought that giving a less power compared to what the child has will prevent the numbers from or the progression from happening. That is not true as of now. It does increase even if you undercorrect the children or give a lesser power to children rather than what they're having. So undercorrecting is absolutely not an answer to reducing the powers in children. Next, in terms of giving wearing glasses lesser time compared to giving glasses all through the day, again it's not a great idea, because wearing glasses less number of hours in a day or only while reading, not the rest of the time, again prompts the eye to grow further. That means the numbers are going to increase even further. What is known to work is basically that environmental modification. We have some optical methods to reduce the numbers from increasing. We also have some drops which can help the numbers from increasing. So why do we have to do this is basically because children are growing very fast. In and around puberty, they grow very fast, and that is why the numbers could increase or jump up to a very great extent. So all these measures are aimed at reducing the progression to an extent that the eye is allowed to grow normally and the myopia or the minus powers don't reach to very high levels in a child. That is essentially the reason why we would want to intervene in a child. So what we are essentially going to do, we are in slide 22. So what essentially that we are going to do is environmental modifications, which could be in terms of outdoor activity, reduced near activity, or sunlight exposure, or limiting the screen time. So what next? How does an outdoor activity work? When you are outdoors, we are looking at a natural light. And the sunlight has a wavelength ranging, what is seen from our eye is somewhere between 400 to 700 nanometers of light. So this essential sunlight will have a wavelength which is around 550 nanometers, which is exactly focused on a retina. So which is exactly focused on our retina, unlike the indoor light, which can have wavelengths which is slightly shorter, slightly higher. That again could prompt or increase the myopia from happen or prompt the increase of powers. Or it can also be because of light which releases dopamine, which again inhibit the axial elongation. So what essentially it means is for children who are wearing glasses, outdoor time, that is staying outdoors, slows down the progression of powers, and for a child who does not wear glasses, it reduces the risk of developing powers over a period of time. So outdoor intervention programs can significantly reduce the myopia incidence by approximately half compared to staying closely indoors. We've all seen this happen during COVID time. That is close to 1.5, 2 years that we have COVID. All the children had online classes. They never stepped out for reasons that we are all aware of for the risk of getting COVID. So what it essentially happened was it prompted children to stay indoors for a longer periods of time, pushing more children towards developing minus power than we would have expected it to if not for COVID. So what essentially it means that is spending outdoors essentially for at least 2 hours every day is very important for a child. One, not to progress if the child already has glasses, and if the child is not wearing glasses, to reduce the risk of developing glasses. So 2 hours of outdoor activity, all of us when we were in school, we had a 1 hour period of mass PT periods where we had an outdoor activity with sunlight exposure, plus in the evenings that we used to play. So all the schools essentially should think of having a 1 hour of PT period or 1 hour of mass drill in the mornings where they have a early morning sunlight, which could be very beneficial for a child. Then looking at near activity. So I think most of the parents are aware that mobiles or the gadgets usage are a important cause for the powers to develop. So when we say near activity, it does not just about gadgets. Anything that you do at near, which is less than 30 centimeter or 40 centimeters away, and constantly doing for 30 minutes in a day is what increases the risk of myopia. How much does it increase? It nearly increases up to 2% for every diopter hour of more near work. What it essentially means is if the child is required to do a lot of school activity. That means the child is already spending 6 to 8 hours indoors and doing a lot of near activity. When the children come home, they again do a lot of near activity in terms of having to do their homework and things like that. So what essentially they have to do whenever they're doing, they keep an elbow rule, as what we say, that is forearm distance between what they read or what they're doing, and not more than 30 minutes at a stretch. After 30 minutes, take a small break, say of a couple of minutes before they continue with reading. 2, they also have less or minimal screen time with respect to gadgets if it is only for entertainment or leisurely activity. Unless it's a mandate for the school, reduce on it. 3, also use their books and sit in open areas to read rather than staying indoors, especially in your balconies or terraces where it has a lot of open space around. Also follow 20-20 rule, as what I said. After 20 to 30 minutes of constant reading, take a small break of 20 seconds, then continue with the near activity. All this will reduce the risk of the numbers from increasing. It is also known that there are other factors like the vitamin D levels. Vitamin D levels, is it a surrogate marker or it is related to the sunlight exposure is not very clear. But when you have a low vitamin D, again it causes the numbers to progress. So checking your vitamin D levels again goes hand in hand with checking of your numbers to understand if that is playing a role. Apart from that, the ambient light. If the children are reading in a very dark room or a dimly lit room, not having adequate light, that again causes the progression of powers. So it is very important that they have adequate light in their setting or in their rooms when they are reading. So there's a direct relationship between the brightness of light and the myopia risk both in children and in adults as well. What is also important is to sum this all up, what is important to do as an environmental modification, encourage your child to go out and play every day for 2 hours as a mandate. If that can include 1 hour of sunlight exposure or 1 hour in the bright daylight and 1 hour in the evening, that's going to be excellent. Reduce the near activities to as minimal. Whenever they are doing the extra activity, like their hobbies can be outdoor hobbies rather than indoor hobbies, especially playing outdoor games, is going to be very, very beneficial for the child. 3, increase the sunlight exposure. 4, reduce the screen time and also follow the 20-20-20 rule. That is, every 20 minutes, take a break for 20 seconds, look at something far away for 20 seconds. This becomes very, very important for a child who is looking at the screens, and the main thing that the children would be doing constantly is going to be reading. Now let's look at some of the interventions that is expected to be done or what is available in the hospital with the doctor to do apart from this environmental modifications. Environmental modifications is something that every parent can do it at home and every child must do it at home to reduce the risk of developing powers or to reduce the progression of powers. What we do as doctors to reduce the progression is going to be beyond this environmental modification, apart from this or in addition to this. So what can be done is either in the terms of drops that you can use glasses or the optical methods to reduce the powers, we can use contact lenses, or we can use a combination of all of these. So if the first looking on to what are the drops that are available, there are various drops which are available currently for reducing the progression of powers. Initially, say a decade back, we didn't have any medication or anything that we knew how to curtail the power. But as of now, we know how to do to reduce the powers in the child's eye. So there is one medication which is available, which is called as a low dose atropine, which can be used to reduce the progression of number. But this medication is to be used only under the care of a pediatric ophthalmologist or a doctor rather than using it over the counter. That is something that is to be kept in mind. So how does these drops work? The eye, as we discussed, the power is dependent on the length of the eye. These drops basically act to remodel the fibroblasts in the eye to prevent the progression of powers, so reducing the rate at which it is increasing. What is to be kept in mind is we cannot stop the numbers from progressing, we can only reduce the numbers from progressing. So when we think of reducing, that means if the numbers would progress very quickly, say 0.5 diopters or more in every 6 months, we intend to reduce this progression which is over and beyond the normal progression. So one of the medication that is available is atropine. So as what I mentioned, it remodels the scleral fibroblasts and thus reduces the progression of number. What do we know about this atropine so far is there are a lot of studies which are done on atropine, say from around 2000, in order to look at which concentration is available, what can be done about it, is there something else that we can do about it. It is shown very, very effective according to 2 major studies that we know of. One is atropine and treatment of myopia progression, and low dose atropine and myopia progression. That is the ATOM study and the LAMP study. So both these studies looked at various concentrations. What they have shown is it reduces the myopia progression to around 60% when we use the drops per se. And the various frequencies or various concentrations that is available, what we have in India is closely 0.01%. What is available elsewhere, which is known to be effective, is around 0.05%, which is known to be a little higher effective than 0.01%. And the details of which is beyond the scope for a layperson, but yes, that is available for us to look at retarding the progression. When we look at the graphs I've just put for you to understand that these are available at various concentrations and they're very effective. Indian equivalent of the study is also being done with a multicentric trial. One of the center was our hospital, was also a part of the study. We found that nearly 54% of Indian children also showed good response with atropine drop. So atropine stands as the mainstay of treatment for us in reducing the progression of powers. So what are the other methods that we can do if the child is not adept to drops or the drops are not being effective? Can we do something else apart from just drops, relying on drops? We have glasses which are available for reducing the progression. Essentially, the eye is like a spherical structure. So any lens would focus the light differently on different parts of the retina. So that is essentially why we can use different lenses which could retard the progression. So essentially it goes on to say for the eye to grow more, uh, if the eye is constantly having a blurred vision, it grows more. If it is having a different contrast at the retina, it grows more. If there is contrast or if there is aberrations which are happening at the retina, it grows more. And if there is the side of the retina is not focused, when the center of the retina is focused, it grows a little more. So all of this kind of contribute to the powers growing higher. So all the lenses which are available are essentially meant to do or meant to correct this. Um, what we are essentially trying to do is, if the eye is like a spear, what we intend to do with the lenses is only focused here, and in the corners of it or in the periphery it may not be focused, it may be focused behind the retina. So if we can get a lens which focuses this in front of the retina, and that there is a clear image all across the retina, is something that we are looking at, and that is what is available. And these are special lenses which probably some of you may have heard in terms of myopic glasses which are available in the market now, which are of various types, which could be called as a DIMS lens, which is called defocus incorporated um, multiple segment lenses, or it could be HALT lenses, which are highly aspherical lenslet target technologies, or you could have KARE lenses, which are cylindrical annular refractive element lenses, or it could be based on diffusion optics technology, or the one Titan has in terms of myoslow lenses. So all of these lenses are based on variations that are created in the lens, where the lens does not have a single power all throughout. It has one single area, or the central area, which kind of focuses on the retina, the surrounding area which kind of creates a area or a blurring, so where the images is fall in front of the retina, which is known to reduce the progression. Or some of the lenses kind of blur the image or reduce the contrast on the retina and thus slow the progression. Or some of the lenses also create higher order aberration, which again slows the progression. So be it any of the way or form, what we essentially intend to do is reduce the progression of lenses. Apart from glasses, do we have anything else that we can do? Yes, we have something, the similar kind of technology in the form of contact lenses. One of the, again, when we look at contact lenses, it's only for older children, not in younger children, who are able to handle the lenses by themselves, take care of the lenses, and look at the hygiene of the lenses. So these lenses, there are certain set of lenses which could be worn overnight, and the daytime the child does not need glasses, does not need contact lenses both, which are called as orthokeratology lenses. We also have, similar to what I described in the glasses, disc lenses, which are diffuse incorporated soft contact lenses, or you have dual focus optic design lenses, which again create the similar effect as in the glasses, which could be used. Are these glasses as effective as the drops that I was talking about? Yes. The glasses are effective to an extent of 60 to 70%, close to that, to reduce the progression of powers. When we are talking of it, we are only talking of if the numbers would increase very higher, it will only reduce the progression. It will not stop it from progressing. That is something which is to be kept in mind. All these glasses and the atropine eye drops kind of reduce the progression, with atropine scoring a slightly higher over the lenses. Again, can we use it in a combination to get more effect? Yes, there are studies which show that it can be used in combination. It works a little better than using it individually again. Again, what is to be kept in mind is all of these measures are to be taken under the care of a doctor or a pediatric ophthalmologist, not like over-the-counter glasses. especially in children, because we are looking at not just the numbers. Okay, -4 has become -5 or -3 has become -6, and that's why we're starting all this. Not essentially, we're looking at a lot of other things. That is, one, the length of the eye is changing or otherwise, what is happening to the corneal curvature, what is the family history of the child, is there any developmental anomalies in the child, is the child having systemic disorders, is the child having any other side effects to any of this medication, probably, what is the ethnicity of the child, what has been the progression over the last 6 years or 5 years, what exactly is happening is to be taken into consideration before starting the drops or the lenses. So it essentially goes on to say that you will have to meet a pediatric ophthalmologist before you start on all this sort of medications. Lastly, we come to a few important things about myths and facts. Another important thing that you'll have to look at in terms of progression or in terms of powers in the eye. So we normally say that, as what I've clarified it before also, we don't have to wait for the child to start talking before we get an eye exam done. So that essentially means that you don't have to wait for your child to come and tell you that the child has a problem. The child has a problem, but it has to be done much earlier. That is, from the age of 5 or before the age of 5, you need an eye exam to be done. And the eye examination does not need the child to be verbal. So we check them at the age of 5 or before using age appropriate chart, or use objective methods to check if the child needs glasses. 2, what is the myth that if my child starts wearing glasses at the age of 5 or 6, the child is going to lifelong need glasses, so I'll delay the glasses wear as late as possible. Not really. If you delay the glasses wear when the child actually needs it, what it essentially leads on to is, as what I said, it can lead on to lazy eye, it can lead on to squint, it can lead on to powers becoming even higher than what it started off with. Then parents, okay, I don't wear glasses, so my child does not need glasses or will never develop glasses, is again a myth. It is based on genetic factors and the environmental influences, a combination of two. Children don't exactly get exactly the genes which you have. There can be mutations, and that could be a cause for it. There could be large amount of environmental influences which causes powers. So being multifactorial, this can develop in any child. Even if you don't have glasses, your child can develop glasses, and it's essential to get a eye check done. The other common thing the parents do ask me is, I'll start giving my child carrot juices every day. I've given him all the vegetables. Every day the child eats vegetables. So why is the power not coming down? It does not come down. It simply does not come down because general health is important for the eye to grow normally, but that does not mean that giving carrot juices will help get rid of the glasses, simply because of the fact that the glasses are an optical error. The eye is not the same shape or the same length. That's why child has glasses. Your eating or drinking carrot juices is not going to alter this, and that's why it does not have an effect in terms of getting rid of the glasses. Yes, it's important for the general health. It's important for the other reasons in the eye. The next important myth that we always encounter is, if my child wears glasses 24/7, the child is going to be dependent on them. Not really. The child never becomes dependent on glasses. It's just that the child realizes that this is the clarity of vision that I can get if I wear glasses, and that's why the child starts wearing glasses more regularly than before. And eye exercises, getting rid of glasses, is a big no-no. There is no eye exercises which can get rid of the glasses. Eye exercises are important for laziness, for squints in the eye, for muscle imbalances and things like that, but not to get rid of the glasses. There is no eye exercises to get rid of the glasses. That is something that has to be kept in mind. So to summarize the whole thing, what it essentially means on to say is, if you have a child and the child is less than 5 years, get an eye check done before the age of 5. 1. 2, if the child needs glasses, ensure that the child wears glasses in order to prevent further problems from developing. If the child does not have glasses or has glasses, in both the scenario, ensure that the child goes out and plays every day for 2 hours. 1. 2, the child has adequate sunlight exposure. 3, the child has adequate light in the room when the child is reading. 4, not more than 30 minutes of stretch of reading. Give a small break and then continue with reading. And if the child's number is progressing or not is known only when you do a follow-up. So every child who wears glasses needs a regular checkup every 4 to 6 months to understand if the number progressing or not. Doesn't mean that the child has to complain that I can't see with the glasses, then you do a follow-up. Not really. What you essentially have to do is do a regular follow-up every 4 to 6 months to understand what is happening. Be aware that there are myths which are running around. Not every child can progress to decrease the numbers, things like that. It does not happen. There are very, very rare instances where the glasses completely regress over a period of time. And all the interventions that I suggested, either in the terms of drops or glasses or contact lenses, are to be done under the care of a doctor or a pediatric ophthalmologist. Don't do it over the counter. Don't just buy drops and start using them in a child unless it's indicated. So this summarizes what I essentially had to tell about refractive errors in children. If there are any other questions that, or if you would want to ask, I would be happy to answer you. Thank you very much.